Well, this disclosure is that it's not exactly percutaneous, but it certainly is a melody valve implant in the mitral position in children. I think for some of these small kids, going percutaneous might still be tough. I'm going to focus mostly on this valve implant in infants. So there are many papers out there now talking about mitral valve repair in the neonate and young children. And the problem with all these papers, and I just listed a few, is that the outcomes are not exactly ideal. There's a lot of residual valve dysfunction. There's a high burden of morbidity and mortality, high rate of reoperation. And basically, when you do this at that age, if you can't fix it properly, you're going to have to be prepared to put a new valve in. And a lot of the repair only delays the time to replacement. So therefore, these surgeons have a very high threshold to bring a neonatal patient for mitral valve repair. So of course, over the last several years, there's been new novel approaches to thinking of ways to implant a valve that can replace a dysfunctional mitral valve in the infants and children. So of course, there are also bioprosthetic valves available. The smallest ones, I think it's in the 12 millimeter range, and some of them are still somewhat new. So what I want to do today is actually just talk a little bit about some of the hybrid techniques that have been used to implant melody valves in the mitral positions. I want to show that these valves, one advantage is that you can further dilate them in the neonate when they're growing rapidly to accommodate the growth and therefore delay the surgical valve replacement. We'll review some of the techniques in the mitral position and how to further dilate. So here's an example, a 3-month-old, 4-kilo baby with the AV canal that was repaired. And after repair, this is what we have: severe residual AV valve mitral regurgitation. I remember discussing this, and the surgeons were very reluctant to try to do another repair, thinking that he might actually just need a new valve if that was the case. So they're just a more example of the MR. And so the options there was, do we try to re-repair it? Likely not going to be successful. Do we put a mechanical valve in? The annulus here only measures 11 millimeters. At that time, the available valve is a 12 millimeter mechanical valve on an investigational basis. These babies would certainly be on lifetime of Coumadin if it was a mechanical valve, small bowel prosthetic valve. And so the discussion came to the possibility of using a mitral valve to be implanted using hybrid techniques. We don't know how long these valves will last, so that's a disadvantage. But certainly we can further dilate it if the baby outgrows it and buy more time until a surgical valve can be placed. So after that discussion. So here's the example of the planning. So this is just the TE. You see that again, the severe mitral regurgitation. We make our measurements. This was 1.13 millimeter annulus. And so we are drawing this to sort of get a sense of what the valve would look like during diastole and during systole. Now, of course, if you look at it, there is also where the red arrow is, there's concern for maybe LVOT obstruction if that valve was long. Now, we know the melody is about 3 centimeters long, and so therefore there are some ways to make it smaller, just to shorten it up to minimize that, but certainly that's a big concern in the little kids. So this is what we look like. So this is what it would sit like in a natural position. But there's also ways that you can suture it either to the atrial septum or to the lateral free wall to try to tilt the valves away from the outflow tract. And that might help to minimize that obstruction in the LVOT. So here's an example of what we're doing here. We take a 3 centimeter long mitral valve, and we're crimping down half a diamond on each side. So therefore you're switching it from a 3 centimeter length valve to a 2 centimeter length. The surgeons put a cuff around the valve, and then we basically fold both sides back so that you end up with a shortened melody valve where now it's 2 centimeters long. So this is what the final length of it. The original length was 3 centimeters long. We know it has 3 diamond cells along the edge. So right now you've shortened it up to 2 diamonds. And so it's modified to 20 millimeters. So this is what it looks like. We also know that if the concern was that if that was in the anterior edge and if you inflate, further dilate, the edge might flare open. So we actually thought that we'd be best if we can sew these edges together so prevent that from flaring to, again, minimize the risk of LVOT obstruction. So with that all done, we are now getting ready to place this in the mitral valve. The surgeons put the sutures around the cuff and basically seat it into annulus. And you see this is being seated. And once we're ready, put it in place, the balloon is put back in there and we inflate it in that manner. So again, this is the securing it, and then finally, in this particular case, we actually used a 12 millimeter balloon. We know that the Melody valve can still have adequate function of the leaflets at 12 millimeter diameter. And so this is the post. You see the valve, you see the leaflet opening and closing pretty well. There's trivial MR at that point in time. And the outflow tract actually looks quite good in this scenario. Again, in this case, the valve was sewn anteriorly to the atrial septum. This is what the kit looks like. 10 months later, the patient started to have higher gradient. The weight went from about 4 kilos to about 8 kilos, so double the weight. And so therefore, you're looking at this, and you'll notice that there's some turbulence across the valve at this time. The outflow tract was a little bit higher as well. And so there's a 22 millimeter gradient at the mitral valve. And we thought maybe this is just the baby outgrowing the size of the valve. So of course the plan was to bring him back and see if we can further dilate it. Of course, we have to pay attention to the circumflex artery. That could be a posterior issue. We have to pay attention to the LVOT and then also look at the valve regurgitation. Are we going to create some? So we planned it all out. I'm going to go fast. Now, this is actually a case that I presented at live case at APCIS a few years ago. And you see that this is the blood pressure at the time. We're monitoring this. And as the balloon goes up, you'll notice that the pressure starts to drop, which I expect because the balloon is blocking the mitral valve. Of course, after we take out the balloon, the pressure never came back up to the degree we had. In fact, there were times that there was some heart block there. And so we waited, and you can see how my blood pressure is going up, and while her blood pressure is going down. So we were wondering what happened, and there was some concern, maybe there's LVOT obstruction, but eventually we realized that there is the stenosis actually had been pushed to the distal part of the valve. And you'll see that when I show you the balloon slips forward a little bit and maybe push some of the intima into the distal valve. And I'll show that to you. In any case, once we opened that up, further dilated the distal end, we took the balloon out, the pressure came back to sinus, and my blood pressure normalized. So this is just the angiograms. There's an MPA showing that look how dilated the left atrium is from the residual stenosis now at the Melody valve. And we do a transeptal puncture. I'm going to go through this quickly. And eventually we get across and we run a wire through, and we have to balloon the septum first just to make a bigger hole so we can get the sheath across. You see that as we deflate the balloon, we advance the sheath. Now we have a sheath in the left atrium. And then with that, we're ready to cross the outflow tract, the mitral valve. So you take the picture, again, looking at the how the outflow tract looks, and then also the ascending order, looking at the circumflex and see what the distance it is from the valve, and it all looks pretty good at this point. So we felt comfortable, we're ready to balloon. Now, we end up using a 14 mil balloon, and you notice that as the balloon goes up, it slips back a little bit. There's a little residual waste. I'll play it one more time. Hopefully it plays. I won't play, but there's a tiny little waste at the distal part of the valve, and as we went up, it slipped back a little bit. We thought that we were able to make it bigger. And when we took this picture, again, there was good flow out the outflow tract. We had a pigtail in there, so we knew that the outflow tract was not obstructed there. But if you look at this picture here, it doesn't look like that. The left atrium is still quite dilated. Of course, this is when the TE was very helpful to show the flow. And then, of course, we were able to further dilate the stent distally, and all went much better. I'm going to show you those examples. This is just the X-ray. So here's the pre-dilation TE. You see the turbulence across the Melody valve there. And We went ahead and did the balloon in there. So the balloon is going up here. You see it's a 14 millimeter Atlas Gold, and see how it slips back a little bit. The distal part was a little narrow. And if you look at this picture after the inflation, you notice the flow across the mitral valve is not as great as I would have wanted. It just looks like it's it's not a perfect good flow across the distal end of the mitral valve. And in fact, if you look at TDE, look at the right ventricle, the function is not very good at that point. In fact, we thought that there was almost seems like as if there was severe pulmonary hypertension leading to acute compensation of the right ventricle function. And in fact, that's what it was. We actually created a more mitral stenosis at the distal part of the valve, leading to LA hypertension, leading to pulmonary hypertension, leading to acute right heart failure at this point. Luckily, we picked that up, and that's just the flow. See how unusual that flow is afterwards, the red arrows. So once we dilated it, and this is the function, and of course, after we were able to dilate the distal part, see the function improve a whole lot more, and the interventricular septum bowed more normally. So that's the initial, after the initial dilation, this is what looks like after further dilation. You see how there's much better flow across the distal part of the mitral melody valve. And so again, just the comparison of the RV function before and after that second dilation. So here's the mean gradient, and went from about 19.4 to about 9.5 afterwards. I'm going to show you a second case, and this is a 6-week-old who had congenital mitral regurgitation and dilated LA. And again, by echo, there was about 18, 19 millimeter annulus, severe MR. And then I'm just going to quickly do this so that I know I'm running late now. So this is a CT showing the annulus is about 17 millimeters. We brought the kid to the cath lab. You see how severely dilated the left atrium is, secondary to the mitral regurgitation. See a lot of regurg there. So in this case, you notice that there's not a lot of coaptation of the mitral valve with severe regurg. And the outflow tract looked pretty good there. So we went ahead again, did a drawing to see how the valve might sit, how we want to sit it. Again, we're paying attention to the outflow tract in this scenario. We're going to try to tilt this away from the anterior outflow tract, and the surgeon will suture it together. So here's just some of the examples, getting the balloon and the valve ready, and the suturings are putting it around the cuff, and the cuff is now sewn to the annulus. It's seated, and once we're ready, the balloon goes in. The valve goes in, and you can see that we can actually inflate this quite easily. And this is an 18 millimeter balloon now. And so this is a pretty normal size valve at this point. We did a second inflation just to make sure that everything is as seated as we want it. You notice that the proximal melody valve, the metal stents are folded back a little bit also. And so this is what it looks like as you inflate it. And then afterwards, this is what it looks like after we're finally done. The surgeons tighten up the sutures, and I think we're all ready to go. And if you look at it, there's just mild, trivial MR after the valve is implanted. Another picture of that valve opening nicely, good flow there. And then the outflow tract looked pretty good there. Even though there's some shadowing there, the valve was actually sewn against the atrial septum, and there was no obstruction there. So the peak, the valve was about peak of 15, mean of 6. There's always a little bit of gradient there, even though it's wide open. LVOT, you'll see that it opens up pretty nicely. And if this is outflow tract there, again, you can see from the Doppler, it's not that high. So we thought it was good. So let me just summarize that the melody valve can be placed in the mitral position as palliation in selected cases. There are hybrid techniques, the left ventricular outflow tract assessment techniques to minimize the valve protrusion in the outflow tract. There's further dilation can be performed to accommodate somatic growth. Beware of the outflow tract, beware of heart block during reintervention, and further studies and longer follow-up is warranted. Thank you for your attention.